Welcome to the Food Junkies Podcast. Here, we aim to bring you the experience, strength, and hope of professionals working on the front lines in the field of food addiction. Our mission is to educate you, the listener, and increase overall awareness about food addiction as a recognized disorder. Here, we discuss all things recovery, exploring the many pathways people take towards abstinence in order to achieve a health-forward lifestyle. We hope to inspire you to thrive rather than just survive. So stay positive, make a change for yourself, and share your journey with others. And hopefully the message will spread.
Welcome to the Food Junkies Podcast. My name is Dr. Vera Tarman, and I am your host today, speaking with Dr. Anna Barbieri. Dr. Barbieri is a board-certified gynecologist and integrative medicine physician who specializes in menopause, perimenopause, polycystic ovary syndrome, and premenstrual syndrome. She completed her residency in obstetrics and gynecology at Mount Sinai Medical Center in New York City and is now an assistant clinical professor. Dr. Barbieri is also a certified menopause practitioner through the Menopause Society and the fellow of the University of Arizona's Integrative Medicine Fellowship. In her New York City practice, Dr. Barbieri provides personalized women's health care, blending conventional medicine with evidence-based holistic approaches. She is the founder of Electra Health, a digital health platform that allows her to use nutrition and lifestyle strategies alongside hormonal and non-hormonal treatments to help women navigate PCOS, menopause, PMS, and other hormonal health concerns. We at Food Junkies are especially interested in what she can tell us about the influence of hormones on appetite, especially during PMS, menopause, and PCOS. So welcome, Dr. Barbieri.
Thank you, Vera, so much. That was a very lengthy introduction. I appreciate it, but what I would love for your audience to take away is that I am a lover of hormones. I find our hormonal physiology to be incredibly fascinating, beautifully complex, and so powerful in terms of how our hormones influence our health, and not just physical, but our mental health. We're going to talk a lot about hunger signals here, I think. And it's a really incredible system. So I am a physician. I am also a 51-year-old woman who's had the experience of numerous hormonal transitions in her own life. I think it's just a really fantastic area that we as women should know more about. I think physicians and healthcare providers should know more about. And I think there's a lot here that we can do ourselves in terms of feeling better. And there is a lot that can be done and a lot that we still need to learn in terms of how our hormones affect us.
That sounds like an excellent approach. So you mentioned that we're really interested in the how hormones affect appetite. If we can just jump right in, and if you can explain some of the hormones like ghrelin, leptin, CCK, but how they regulate appetite, and then specifically how hormones such as estrogen and progesterone can impact on those.
Sure. Let's maybe start with the definition of what a hormone is, because I think that puts it in context here. So a hormone is basically a molecule that, although produced in one part of our body, can have wide-ranging effects on multiple body systems and multiple organs. So there are currently about 50 plus hormones in the human body, more if we count some other molecules here. Often when patients come to see me, what they mean by hormones is not ghrelin and leptin, which we're going to get into, but actually sex hormones. And for women specifically, we have three main sex hormones. That is estrogen, progesterone, testosterone, but we do have some other ones such as DHEA. And of course, we have other hormones. And when we talk about the hormones of appetite, certainly sex hormones have an influence, but here we center more on leptin, ghrelin, and CCK that you just mentioned. And of course, who isn't thinking these days or hasn't heard of things like GLP-1s, right? That's such a topic of a conversation. But when you think of leptin and ghrelin, so leptin is basically a hormone of satiety. It is produced after we eat. It signals us to stop eating. It has a direct relationship with estrogen Estrogen basically makes us more sensitive to leptin. So that's a quick window into what can happen when estrogen starts to go down, both in a menstrual cycle, but also in conditions such as perimenopause and menopause. Ghrelin is the hunger hormone. In medical school, we have to learn so many different terms and we had to memorize so much. So the way I remember ghrelin is if your stomach is going grr, it's hungry. So ghrelin is the hunger hormone. Okay. Certain sex hormone may make us more prone to ghrelin effects, such as progesterone, for example. That relationship is not worked out so well. And then we have CCK. So CCK is made in the gut, and it's particularly released shortly after we eat fats and proteins. When you talk about hormones, we tend to oversimplify things. And I do want to stress that because I think sometimes what we take away is, oh, high estrogen, good. Low estrogen, bad, I gain weight. Or high leptin, good because I'm not craving foods. But it's not like that. Everything is complex and interconnected. So I would not, even from that description, I would not take away the conclusion that maybe we can just shift this or that, tinker with one thing, and the whole system changes. We are this amazingly complex system. And a lot of these things we're just learning about.
Okay, good. Comment on how stress or cortisol affects that, and before we get into each of the specific conditions.
Oh, sure. So cortisol is an essential human hormone. We all make cortisol. There are states in which not enough cortisol is made, and there are states in which way too much cortisol is made. Those conditions tend to occur on the extremes of cortisol production. And they are major abnormal medical conditions. Too little cortisol is called Addison's disease. Too much is called Cushing's syndrome. But there's a whole range of cortisol in between. Cortisol has a certain pattern in which it's released during the day. It tends to rise in the morning and it falls over the course of the day, should be low at night. And cortisol is we call it the stress hormone. In modern life, often what we face is increased cortisol that is sustained for too long. We need cortisol. We need it to go up in response to stressors. That's what gives us energy. That's what gives us the ability to run away quickly from something. But currently, the way many of us live, there's so many things coming at us from all the time, from so many different sources that cortisol is up. And what that does is basically it makes your system believe that it's under a threat and your system needs to conserve energy all the time. So elevated cortisol that is sustained in an abnormal way can definitely contribute to cravings, particularly to calm the nervous system. What most humans want in that scenario is carbohydrate and sugar. That will then have a cascading effect on hormones such as insulin, and then cortisol through this mechanism of trying to conserve energy because, oh my gosh, just in case we need it for something worse, can make it also more difficult for us to engage in activities that serve to moderate our weight, energy, and weight management altogether.
So the formula to that is more cortisol, more weight gain.
Yes. Yeah. And the extreme part of that, so Cushing's disease is actually, we look for that if somebody has unexplained, very rapid weight gain, that is a potential diagnosis that we need to consider.
You mentioned earlier that we can't really look specifically at estrogen and progesterone individually, that we have to see it as a complex system working with each other. And so can we understand some of these conditions that I'd like to talk about, like PMS and perimenopause, menopause, as variations of that symbiotic relationship?
For sure. And I think, Vera, you mentioned we have about an hour for this podcast. I just want to warn you and everyone, I could talk about it, I think, for a week. It's just so very interesting and so intricate, but I'll try not to do that today. Yes. Again, to describe it from the basics, let's take a typical menstrual cycle.
Yes.
The typical normal menstrual cycle that cycle will start with its first day. By definition, the first day is the first day of a bleed or a period. And a typical menstrual cycle in a reproductive age woman will be roughly somewhere between 3 and 5 weeks, with that average book perfect cycle being 28 days. Typically, estrogen and progesterone are very low on day one. Estrogen is then going to rise for about 2 weeks. It's going to peak around ovulation, which in a 28-day cycle typically will happen around day 14, so 2 weeks later. And the process of ovulation will trigger our bodies to make progesterone. Basically, without ovulation, we do not make progesterone unless we ingest it from other sources or take it in from other sources. Progesterone then will rise, and then a few days before a period, and that process will start about a week before, both progesterone and estrogen are going to fall. And it is the fall in these hormones, particularly progesterone, that will make our bodies recognize it as a signal to bleed again. Then bleeding starts and the whole cycle starts again. So we've got estrogen production rising in the first half of the cycle, peaking midway through, then progesterone rising in the second half, and then both of these hormones falling before a period.
And PMS is when the progesterone.
PMS is premenstrual syndrome, and it's so interesting because premenstrual symptoms, sometimes they are predominantly physical: bloating, water retention, weight gain, breast tenderness, for example. But there's a whole slew of emotional PMS symptoms also: irritability, anxiety, depression, emotional lability. Sometimes it can be fatigue. Depending on when those symptoms start, we think that it is either the progesterone sensitivity in someone, or it's actually the fall of these hormones that causes it. We'll tell you, for example, in early perimenopause, what we see, and that's a time in a woman's life when progesterone starts to decline first. PMS typically gets worse. And it's not because of progesterone, it's actually the decline in it and that slight imbalance between how much of estrogen and progesterone we're making then. So I don't want to blame PMS on progesterone. Some women are actually helped with extra progesterone during this time. And it hasn't been very well worked out. Why do some women have it? Why are some women sensitive? Why are some women not sensitive to this change?
You mentioned that in perimenopause, that it can be the basic decline of progesterone. Would it be fair to say that perimenopause is basically PMS overdrive, PMS constant?
Early perimenopause.
Yeah.
So perimenopause can last what feels like forever, be up to a decade.
Yeah.
It's like puberty. It's some of the same, almost the same symptoms that occur not necessarily because something is high or something is low in terms of hormones, but because of how unpredictable and wide those changes are. Early peri, typically progesterone goes down and estrogen is all over the place, sometimes very high. That feels like tremendous PMS, breast tenderness, bloating, water retention, weight gain, waking up at 3 a.m. for no reason whatsoever, feeling of overwhelm and anxiety that comes along with kind of a natural rise in cortisol during this time. All of it. It's not until we move to this next phase when estrogen really starts to go down and stay down. So now we're starting to miss periods and have symptoms of low estrogen. So the classic symptoms of menopause: hot flashes, night sweats, vaginal dryness. Yeah. Those are going to come in that late perimenopause period and then into menopause. Yeah.
What happens to appetite in the perimenopause phase and then in the menopause phase? Because perimenopause, that's when people crave to eat, and especially crave chocolate. That's what I hear all the time.
It is like PMS on steroids.
Yeah.
Like that.
Yeah.
We don't know whether it is the drop in progesterone and the relative fluctuation of estrogen, or is it how quickly estrogen rises and falls that directly influences appetite?
Interesting.
Does it do that directly, or does it do that through their effect on leptin and ghrelin and CCK? We don't know that. But it is that hormonal roller coaster it's difficult to anticipate because every cycle can look a little bit different. And with that big fall before a period, in terms of both estrogen and progesterone, that is when a lot of women tend to crave these sweet things and sweets, carbohydrates, densely caloric foods, and all of that. And we have to remember, like in this phase, our cortisol is higher. So that's another driver of appetite. We may be not sleeping very well. So if I haven't slept, if I've woken up 5 times at night, I'm going to want my coffee, maybe with some sugar in the morning. And if I'm going to have that, maybe I'm going to have some other stuff that may not be the best for me, but I'm going to crave that. I'm going to crash at 3 p.m. and want it again. So I think it's really hormonally dependent in this phase.
PMS, that was also a time when sexual libido was really high. I mean, is there a relationship there?
It's a great question. And sexual health is such another very complex and interesting part of our health. There are studies looking at libido specifically in the menstrual cycle, and it tends to actually correlate with estrogen peaks. So it's going to peak around ovulation more so than in the premenstrual period.
That actually makes sense, doesn't it? Evolutionary wise.
Sure. If our purpose is to reproduce, so the greatest chance of getting pregnant is going to be right before ovulation, and that's when it's going to.
That's mid-cycle. And I'm just thinking that I remember when it was on my period or just before that there was the most appetite.
Yeah. And it's also very individual. So I think this pattern, it varies quite a bit. Let's go back to progesterone, how we're starting to get glimpses of how important of a hormone it really is. In the world of perimenopause, menopause, and hormone therapy specifically, progesterone used to be thought of very simplistically as a hormone that just protects the uterus from the effects of estrogen.
And has some kind of testosterone-like effect.
Some, yes, to a degree. It used to be thought that the role of progesterone is just to support an early pregnancy and prevent the uterus from developing cancer. We now understand that progesterone has real brain and mental health effects. In fact, and this is the interesting part, in fact, one of the newer treatments for postpartum depression, right? So what happens when women deliver babies? Their bodies are very high in estrogen, progesterone. That baby comes out, the placenta comes out, and you fall off a hormonal cliff.
Yes.
We don't know why some women develop postpartum depression. In women who are not responding to standard treatments, an infusion of a medication that's chemically similar to progesterone can potentially reverse postpartum depression in a very short time. Wild. It's such a great example of how powerful these molecules are.
Yeah, I always thought that, this is just my thinking, I didn't read this, that part of that postpartum depression was because there was a deficiency of oxytocin, because often mother doesn't have an attachment to baby. Is there some role there?
Potentially, yes. Yeah. But is that the more direct link? Or is it that some women are so sensitive to progesterone decrease?
Yes.
They don't make oxytocin. And then the whole thing builds on itself. Yeah. And the other interesting thing is women that have premenstrual depression, that be a risk factor for postpartum depression, and women with a history of postpartum depression will have more depression and anxiety in perimenopause and menopause. And whether our food cravings, because I do want to say, I have so many patients who come in with struggles with, I think, their relationship with and to food, weight concerns, and it's really so much thinking around it. Like, we also tend to oversimplify it, just a matter of will. It's not. It's like our food behaviors represent how our nervous system is trying to adjust. Whether that is mostly the interaction of estrogen, progesterone, leptin, ghrelin, or whether it's just the response of your nervous system to the stress that it's dealing with, your nervous system is trying to soothe itself. It may soothe itself through many different behaviors. And we see that in the field of addiction quite a bit, whether that is alcohol, whether that is social media, whether that is sugar, anything, we tend to reach for things that will, in the moment, make us feel better. So,
do you, as a gynecologist, see, I'm sure you see a lot of women reaching for food. Do you see that there's a higher rate of alcoholism as well in menopause versus prior to?
yes, there are some statistics on it actually showing that women in midlife tend to reach for alcohol more. That is, and again, whether that is driven directly by hormonal changes or whether it's a really behavioral response because you're trying to soothe your cortisol-ridden nervous system, or you have insomnia, a very common symptom in perimenopause. Over 60% of women will report that.
Yeah.
And alcohol is going to be something that is going, maybe will enable you to fall asleep faster. Alcohol is actually terrible for your sleep overall. It's going to lead to wake ups, to fragmented sleep and less restful sleep. So we don't know the answer to what's at the core of it, but certainly I do see women reaching for it quite a bit.
And obviously food, because that's an issue.
Yes.
And it's particularly an issue because in menopause, women are more likely to gain visceral fat as opposed to subcutaneous fat.
Absolutely. This is another interesting area. So we know that the decline in estrogen, and even though in those early years of perimenopause, estrogen may be high, but it's up and down, and over time it is coming down. Estrogen results in an estrogen loss leads to our bodies changing shape, right? If I remember my grandmother when I was little. My grandmother was in her mid-50s. Her belly came in the room before the rest of her came in the room. So that's like that. I still have that image of her. And we see ourselves transform our body shapes, which is, by the way, expected and quite usual in that perimenopause to menopause transition. So loss of estrogen is going to shift our fat deposition from butt and thighs onto the stomach, including both subcutaneous, so under the skin fat, but also visceral fat. Visceral fat is fat around our organs. That is not a great fat to have. That's a hormonally active fat that is also going to produce inflammatory markers, raise our risk for high blood pressure, diabetes, chronic inflammation, likely certain types of cancers, things like that.
So we know then that if people eat high carbohydrate diets, that's what's going to happen. But what about those of us who are attuned to this and are avoiding refined carbohydrates, either keto or just low carb? Can we avoid getting that visceral obesity, that belly fat?
To a point, possibly, because not completely, because it's also under the influence of genetic factors and certain other hormonal factors. There are people, and especially if you look at various diverse populations around the world, are actually even populations who are genetically predisposed to having visceral fat, but they will appear quite thin. For example, women in many places in Asia, that's a well-known phenotype. I do think, and I have to say, I don't think there's a perfect diet for all of us of a one type, but lower refined carbohydrate, whole food, high fiber, moderate to higher protein type of eating will modulate that gain in visceral fat somewhat.
But that tendency to gain weight around the waist, we can't really avoid that once we hit menopause.
It is incredibly difficult to prevent that and get rid of that.
Right.
That's not to say we should not engage. Feel like I have this conversation multiple times every day, and I'll just with myself, Amanda, I'm 51, and with my patients. So, my philosophy is that there are certain changes that come with perimenopause and menopause that are unavoidable. And I think we cannot go back to 25. There is nothing that will take us back there. But that does not mean that we cannot change how we live, change the things we do, or use certain tools that will modify the process and will set us up for better health in the future.
Yeah.
I think there's plenty of room to improve our diets and lifestyles, and we have tools now that we can use to help this process. But I don't necessarily think that a small change in one's appearance or weight should lead us to an unhealthy obsession with fighting against it. It's like an inflection point in our health. And it's a normal process.
Yeah.
It does change a lot of health markers and a lot of processes. And what happens in terms of our metabolism in menopause is that it does slow down. We tend to burn less energy with the same activity. Our cortisol levels tend to go up, and we just talked about that.
Yes.
Where estrogen and progesterone and testosterone go down, we now develop this kind of more fat around our bellies. And specifically when it comes to visceral fat, that acts like an organ itself that tends to potentiate everything. And our fat cells become more resistant to weight loss efforts. So it's everything together.
Hey, Food Junkies listeners. We're just going to take a quick break here to share with you something our team thinks could help benefit your recovery with food, body, or self. Thank you again for listening. Hey, Food Junkies listener, Clarissa Kennedy here. And I'm so excited to highlight our next course, Befriending Your Body, taught by Christina Dobbins and I. Here's the truth. Recovery isn't just about white-knuckling cravings or managing symptoms. It's about coming home to your body. For so many of us, years of dieting, binging, restricting, or numbing with food have left us disconnected from our most powerful ally, our body's wisdom. Because when you can't feel, you can't heal. Without interoceptive awareness, it's almost impossible to tell hunger from stress, fullness from fear, or comfort from craving. And without embodiment, we stay stuck from the neck up, trying to rely on rules and willpower instead of compassion and trust. That's why the Befriending Your Body program is different. You'll learn how to rebuild a safe, respectful relationship with your body and food, practice nervous system-based tools to regulate stress and urges, replace shame and self-criticism with kindness and compassion, anchor recovery in wholeness, resilience, and embodiment. This isn't therapy. It isn't just another support group. It's a structured, research-based journey grounded in polyvagal theory, mindfulness, and what we all need more of, self-compassion. And the results speak for themselves. One participant shared, "This program helped me move from self-criticism to self-compassion. It gave me the tools to finally trust my body again, and that changed everything." Our classes are going to run on Wednesdays from October 1st to October 19th, starting at 11:30 a.m. to 1 p.m. Eastern Standard Time. Spaces are limited to just 15 participants, and the cost is $397 US. Your recovery deserves more than symptom management. It deserves transformation. Join us and discover how interoception and embodiment can help you move from surviving to thriving. Now back to the show. If you have enjoyed this episode, please let us know. We love to hear from you. Kindly leave us a review on whatever platform you listen to our podcast on. We love getting feedback from our listeners.
And the other thing you haven't mentioned, the thyroid. Why is it that so many women tend to become hypothyroid? And that has an effect on weight and probably the food cravings as well.
I'm so glad, Vera, you brought it up. This is I think it's an underdiagnosed and underrecognized condition in women.
Yeah.
A lot of women, especially in perimenopause, develop thyroid abnormalities, specifically of the autoimmune type. So I don't know if you
thyroiditis.
have heard of thyroiditis and Hashimoto's, much more prevalent in women.
Why?
More prevalent in midlife. All autoimmune conditions are more prevalent.
Oh, really? Oh.
Women. Yes. And there is an interplay between thyroid conditions and perimenopause. In fact, hypothyroidism, so having an unusually low amount of thyroid hormone, can often look just like perimenopause or menopause. fatigue, weight gain, hair loss, dry skin, all of it across the board. This is one among many others, one aspect of health that we actually always test for when women come in with presumed just perimenopause or menopause symptoms, because you don't want to miss it.
Yeah. Could they still have what a general doctor would say is, that's a normal thyroid? Would you be more sensitive and say, actually, it's a little lower than I would expect?
I would agree with that. I think the range of normal. So in typical, let's say, a primary care setting, often we get one test for our thyroid health, and that is a test called TSH, or thyroid stimulating hormone. That is not the whole story. There are other indices of thyroid health that we can test for. So in our practice, especially for women with these types of complaints, we want to get a picture of their entire thyroid health. And we want to correlate that with how they are feeling. And while you may be in what's called the normal range, there's also something called the optimal range. So being in the normal range doesn't necessarily mean that you're feeling your best. It just means that you're in the 90% of the population that falls within this number.
Polycystic ovary syndrome. That's another one where appetite seems to change, or it's harder to feel full. And if you could comment on that, please.
Sure. PCOS, or polycystic ovarian syndrome, it sounds like such an ovary dependent condition, actually a metabolic condition at its core. It's very prevalent. There are statistics now that anywhere between 12 up to 20% of women may have PCOS.
Wow.
It's the most common reproductive hormonal condition in reproductive aged women out there. It has a number of different hormonal patterns that are associated with it. The first one being that ovulation is actually less regular or even absent. Without ovulation, we don't make progesterone. Without progesterone, we don't have a period. So PCOS should be on the list of potential conditions for any woman with irregular periods.
Right. Wouldn't that be like saying that somebody with PCOS has a similar presentation as menopause or perimenopause?
No, because PCOS...
With too much estrogen.
PCOS, someone with PCOS, estrogen will be made, but without progesterone.
Okay.
Menopause, once we are in menopause, so that more than 12 months have passed from that menstrual period, we're not making much estrogen or progesterone.
Okay.
PCOS, we're making estrogen, but not a whole lot of progesterone.
What does that manifest as?
Irregular periods, typically. It's going to be associated also with typically higher than normal testosterone and other androgen levels.
Okay.
So we can have acne, hair growth on the chin, hair growth around the nipples, sometimes female pattern hair loss. And it's also can be associated with insulin resistance, weight gain, more difficulty losing weight. Having said that, PCOS exists on a scale of severity and in different types. So the type that's associated more with weight gain, high risk for diabetes, obesity, hair loss, acne, very irregular periods, that's a more extreme type. And you have women on the other side that have milder phenotypes. Then in early perimenopause, that's marked by estrogen production, but progesterone is going down. That can be indistinguishable from PCOS.
Yeah, okay.
It can look completely the same.
Yeah. What about appetite? How does PCOS affect appetite?
That's a great question. Plenty of estrogen, right? So leptin should be okay. But because of the tie between PCOS and insulin metabolism and how we process carbohydrates specifically, the whole thing goes awry. So insulin resistance is a major feature of PCOS. And that is why certain types of nutritional interventions and often movement or exercise and then weight loss itself through whatever means we get there associated with improvement in PCOS.
Okay. But is appetite worse with PCOS or the same as somebody else?
It depends on how severe PCOS is.
Okay.
Because of...
I mean more cravings.
Yeah,
sweets.
it can be because of in insulin resistance, we tend to crave more sweeter and more carbohydrate-rich foods.
Okay.
When we eat those foods, our blood sugar is not going to be as stable, and that will lead to greater cravings sooner again. And it's like the wheel that speeds up on itself.
Now, about the GLP-1s, which we mentioned earlier, do you worry about what's happening with the GLP-1s and how it might affect the woman's reproductive system?
I have many opinions on GLP-1s. I do think that they are an incredible tool for the solution to the obesity crisis that we're facing. I think we see every other day there is a new study that comes out about the benefits of GLP-1s.
Yes.
Recently, just this week, my training is in obstetrics and gynecology, and I used to be an obstetrician for many years before really focusing on hormonal health. There's an article that women that use GLP-1s prior to pregnancy have less adverse pregnancy outcomes.
Wow, really?
Less preeclampsia, less preterm delivery, less hypertension, and it's not necessarily the GLP-1 itself. It's just the correction of your metabolic health.
Yes.
And I think bottom line is it is better to be metabolically healthy than unhealthy. And not always, but often carrying too much weight means that we are metabolically unhealthy. Not always. We can be metabolically unhealthy with normal weight.
Yes.
Also. So I do think we need to accept that. Now, personally, I would love to see more emphasis on lifestyle medicine, lifestyle interventions, nutrition, correction of our tremendous stress patterns that happen because of so many different factors in our society, where that's being overworked, financial stressors. I take care of midlife women mostly. You have a pressure cooker of worrying about your kids, worrying about your parents, worrying about finances, worrying about your medical needs, worrying about what's happening in the world. So I would love to see efforts directed at just how we live on a societal scale, on a personal scale, efforts directed at making our food better, healthier food more accessible, healthier food easier to get, cheaper. But I can't deny that GLP-1s for the right person can be a very important tool in terms of corrections of underlying metabolic disease. We do use them in our practice. We always couple them with nutritional guidance and with introduction of hormonal manipulation, whether that means lifestyle, whether that means very judicious use of certain supplements, or that means hormone therapy. I have a love-hate relationship with GLP-1s.
Yeah. Can we talk a little bit about HRT? And then I want to talk about supplements and lifestyle change in closing. So HRT, is that given we see the impact of estrogen, would you be somebody that would recommend HRT therapy, especially if a person is struggling with food and weight?
The answer is yes. HRT is such a huge topic, so I think maybe we can distill it down to 2 minutes, which I'm going to have trouble doing here.
Okay.
By the way, HRT for menopause is getting rebranded to HT or MHT, so menopausal hormone therapy. But for this conversation, so many of us still use it interchangeably. So whether we say HRT or MHT, we mean the same thing.
Yes.
So hormone therapy for perimenopause, menopause is the most effective way of dealing with acute symptoms of hormonal withdrawal. So whether we're looking at hot flashes, night sweats, vaginal dryness,
insomnia.
It's also used for certainly anxiety and depression for perimenopause. And it definitely can modify some of those later risk factors. For example, it can reduce the risk for osteoporosis, important topic for another day.
Yeah.
There are data to suggest that hormone therapy may be beneficial from a cardiovascular standpoint. And lots of women simply feel better. In terms of their mental health, there's a debate going on how it affects neurocognitive health in terms of effects on future risk of dementia, right? So many of us have brain fog and we worry that we're going to have Alzheimer's. So many of us see our older relatives struggle with that condition. That's still being worked out, but so many women feel better. Maybe it's because we're sleeping better with it. Maybe it's because just there is less of this hormonal up and down, but that's to be worked out later. So yes, we do use hormone therapy quite a bit. It's safest to use it starting right at the onset of menopause or in late perimenopause, although there are some things we can already do in early perimenopause to stabilize these hormonal fluctuations somewhat. I think that the question is, would cravings get better with hormone therapy? Potentially. There is not that much great research on this topic.
But possibly some of that weight around.
Data that shows that we may gain less abdominal weight gain with hormone therapy. Unfortunately, hormone therapy does not make people lose weight.
Okay, well, that's good to know.
Yeah. I will tell you, Vera, that in our practice, and this is not guideline based, this is not in place yet, what we are seeing clinically, and this is just our clinical experience. I don't want to say that this is based on literature or guidelines.
Yes.
When we see patients who are struggling with metabolic disorders, chronic inflammation, and obesity, we actually start them on a program of metabolic care first and add hormone therapy as the second layer, usually 1 to 3 months from the beginning.
Okay. And you would never start somebody, I think it's 10 years after menopause is not recommended.
It's not like a hard line in the sand. It's more like a line in the sand than a hard line.
Yeah.
There is more risk to starting hormones 10 years past that last menstrual cycle, but there are select patients that I would start. Okay. Very individual. Yeah.
Let's talk about non-medicinal approaches that you would think would be best for hormonal health.
It depends on what we are talking about, whether we're talking about PMS, perimenopause, hot flashes, things like that. We start with lifestyle interventions. I cannot stress enough how important it is for us to engage in activities that reduce stress. However we can find it. I have so many patients who tell me, I went on vacation for a week and I am feeling so much better. It was different food. The case, but it was also a distancing of ourselves from all the daily stress. To me, the solution is not, none of us can go on vacation every other week. The solution is to find a little bit of vacation time in our everyday life.
That's a nice way to put it.
Every day, a little bit of vacation time in every week. It's difficult. It's difficult for me. I tell myself this all the time. Super important. I think exercise or just physical movement is a very potent tool that we can use for hormonal health. It can help with insulin. It can help with cortisol. It can help with your sleep cycle, people to simply feel better. Then going out in nature is a very important tool. Nutrition, completely overlooked. We don't recommend it enough of nutritional interventions in medicine. I think especially midlife women's health calls for reevaluation of how we are nourishing our bodies, and changing is a little bit modifying it at this time. There are also some supplements that can help.
Yeah, please tell us.
Yeah, depending on what we're looking at. And some supplements is a whole other talk we could do for probably many hours. We have to be careful with supplements because, frankly, some are made better than others. There's a lot of blends that are coming onto the market now saying that they will fix anything and everything that ails us. Typically, those blends will not have enough things in them to have a clinical effect. So when I think of supplements, I think of supplements that are meant to replete nutrients. They're going to be things like your B12, your vitamin D, magnesium, things like that. I think some of them should actually be based on levels. So we, for example, check B12 and vitamin levels for our patients and replete that accordingly. Magnesium is a little bit different. Magnesium is a very safe supplement to take. There are different types. Some are better for sleep, some are better for cramps, some are better for constipation, for example. But we often suggest magnesium to our patients to help with these particular symptoms, especially when it comes to PMS, early perimenopause, and menopause. And then there are supplements that we use in order to potentially manipulate hormones a little bit. And I want to be very clear, no amount of Vitex, magnesium, yoga, or healthy smoothies is going to be the same as using, for example, hormone therapy for severe menopause symptoms. It's just not the same, but there are some things in the sort of natural category that may be helpful. So, for example, I'll just give you the list of my sort of 3-star supplements. Okay. One of them is Vitex. It goes by the name of chasteberry. It can be used for PMS and early perimenopause. Another supplement is called a DIM, stands for diindolylmethane. It affects how our bodies metabolize estrogen, and it may lead to actually improved estrogen metabolism, especially in those high estrogen phases like PCOS, early perimenopause. Another supplement I use quite a bit is ashwagandha. Ashwagandha is an adaptogen. So adaptogens are compounds or molecules that can affect our stress hormones and cortisol in particular. But it's very individual. So there's plenty of others. We use supplements, again, very judiciously. I do think that we're all subject to our social media feeds that try to sell us lots of stuff.
Yeah.
More stuff is not better. Supplements can interact with medication. Too much supplement use has been linked to abnormal liver function tests. So to me, all of these are tools that are meant to be used in a smart way for each individual patient.
And better to be done with a physician or somebody who knows these supplements.
Yeah. And I would say, especially for women that may be at higher risk for hormonally driven conditions, right? We spoke about how important hormones are, but hormones can also be involved in some abnormal processes, uterine fibroids, PCOS we mentioned, breast cysts, uterine cancer, breast cancer. So we need to be careful with supplements, especially in those women.
Right.
And specifically supplements for menopause, some of them will have estrogen-like activity, even though they're derived from plants. And those supplements, for example, I don't use for my breast cancer patients.
That would make sense. Yeah. Okay. So if a person does use supplements wisely and does a lot of the lifestyle changes, is there a way, is HRT or MHT?
MHT, yes. Yeah.
Is it inevitable? Or can a person age gracefully without?
I think we can age gracefully without MHT. I think we've been doing it for a long time. I do have to say, though, that up until now, and this is something none of us know, and I wish I could live another 300 years to see how this is going to unfold, because we are living much longer now. Life expectancy is about 82, 85 now. It didn't used to be that long. We used to die much earlier. Right now, we can live for a long time, but typically that last decade doesn't look so great.
That's true.
So it's not about just living longer or living long. It's about living healthier and to the fullest.
Yeah.
I think the question that really has not been answered is continuation of our hormones, possibly linked to improved health much later on. That we attempted to answer that question about 20 years ago by using certain types of HRT in a certain group of women. So a lot of issues with that study we understand now, but the way, and again, that's maybe a complex topic for another time, but we saw that HRT use, the specific regimen used in that specific group, did not result in better health necessarily within the Women's Health Initiative.
Yeah.
So they gave kind of synthetic hormones to a group of women who, on average, these women were in their early 60s.
Yeah.
So we don't know if we can extrapolate the conclusions from that study to hormones that are being used now, which are much more bioequivalent to what our bodies make. Potentially, and at younger ages. So we don't know this answer. And I think it's a very individual decision. Lots of our patients do use hormone therapy. That is what they come to us for. But we also have many patients who, for certain reasons, don't want to use it, and that's totally fine. And certain women who cannot use it because that means that their risk of certain conditions would go up. So my message is, hormones or no hormones, we can all age well and be involved in our own health and aging well.
You explain this very well. Do you have anything that you've written that I can suggest people read?
I have been extremely busy, so I have not written things yet. I do have some plans coming up in the next few months, so I will circle back to you and we'll do that.
Because the next question is, what's next for you? So that you are actually writing something.
However, I'll give a plug to a different book that I was quoted in, and that is How to Menopause by Tamsin Fadal.
How to Menopause?
How to Menopause, yes.
Good.
And so Tamsin and I had a number of conversations on this topic, and I am quoted in that book.
Okay, that's great. If you could send me that link, I'll put it in the show notes. Okay, so I have one more question, and that is our signature question, which is if you could tell a younger version of yourself something about sugar, ultra-processed foods, and hormones, what would it be?
It would be, don't overdo those foods. Live intentionally, including how you nourish yourself, but don't blame yourself and don't catastrophize when you happen to eat those foods.
Because the hormones play a strong role. Yes. Okay. I thank you so much for your time in talking about this subject.
Thank you so much, Vera. My pleasure.
Thanks for joining us this week on Food Junkies Recovery from Food Addiction. Make sure to join our Facebook group, Sugar Free for Life Support Group, I'm Sweet Enough. Molly and Clarissa are food addiction professionals who offer one-to-one counseling and group coaching through Sweet Sobriety. Please subscribe to our show so you never miss an episode. While you're at it, if you found value in today's episode, we'd appreciate you leaving us a review on your favorite platform. Your feedback helps grow our show and allows us to reach others who need to hear this message of recovery. Don't forget to pick up a copy of Dr. Tarman's book, Food Junkies. And as Vera always says, the power is ours.